all we are going to Yesterday we were not able to do because of some internet issues. Okay, today also it was like initially some initial glitches was that I don't know some morning time there is some jerking in the internet. Okay, so now we'll go into our leftover part because time is very less. Okay, so vocal fermenters we didn't discuss I think so. From vocal fermenters I'm going to start. Okay, so what is vocal fermenters? Okay, so vocal fermenters is a palpable parameters, okay, palpable parameters where you're going to make the patient to tell some number, okay, like 1111, okay. When the intensity is increased, okay, when the intensity is increased, then it is going to be seen in few conditions where there is solidification. Okay, solidification. Okay, so what is this solidification? Okay, the solidification is seen in conditions like consolidation. Okay, consolidation. Okay, so consolidation is the thing. Okay, okay. So this is going to be um, the one which is going to be very important. Next is cavity. Usually a large cavity, okay, large cavity is the one is going to be showing increase in vocal fermenters, okay, vocal fermenters. That is very important thing, okay. So excuse me. So that is going to be very important thing. Okay. So you have to take note of this whenever you have any patient coming to you with the consolidation and cavity, you have to see for vocal fermenters. Second is whenever the sound is decreased, okay, then it is going to be seen in conditions where there is going to be no quality lung tissue or the lung tissue is far away from the chest wall. Okay. So when you will have a no quality lung tissue, whenever there is fibrosis, okay, collapse, okay, or whenever the lung tissue is far away like this, in cases of pleural effusion, pneumothorax, okay, pneumothorax, okay. So this is very important thing, okay. Then here you're going to do something called tactile parameters also. What is tactile parameters? Tactile parameters is palpable adventitious sounds, okay, palpable adventitious sounds. Palpable adventitious sounds. Okay, what is this palpable adventitious sounds? Okay, adventitious sounds. Okay, so whenever you palpate, okay, and during palpation, if you are able to hear when you are able to feel the Ronchi encrypts, okay, whenever you are able to feel the Ronchi encrypts, then it is called as tactile parameters. Okay, next is friction parameters. Friction parameters is again a palpable rub. Okay, this palpable rub usually whenever the patient is having empyema, you can see the palpable pleural rub. Okay, and this is very important thing to feel, know and feel. Okay, so this is going to be few important things which are very vital in your exam. Okay, very vital in your exam. Okay, so these things are definitely going to be asked in your exam and you should be able to answer these things in your exam. Okay, next is important thing is percussion. Okay, percussion. Okay, so percussion is very important because you most of your questions they're going to ask around the percussion. Okay, so whenever you're going to go for percussion, you have anterior percussion, posterior percussion, and axillary percussion. Okay, these are the areas of percussion. Okay, so whenever you are going to check for the anterior part of your chest, okay, so you have to make the patient to sit straight, hands by the side of the patient, okay, hands by the side of the patient. Then posterior percussion, okay, posterior percussion, okay, what you're going to do, you're going to make the patient sit like this and you're going to make the hands crossed like this, okay, and posterior part you're going to percuss, okay, and axillary percussion, what you're going to do is you're going to tell the patient to keep the hands over the head like this. Okay, this we have already discussed, I think so. Okay, so these are the methods of percussion. Okay, and how the patient has to be positioned while percussion. Okay, இது இல்லாம ரொம்ப important one. Okay, important one which is called as the rules of percussion. Okay, rules of percussion. Okay, so the direct Direction of percussion is always from resonant to non-resonant area. So always go from normal side to abnormal side. Okay, and you have to compare both the sides. Okay, then you have two fingers here. The first finger is called as fleximeter. The second finger is called as flexor. Okay, so what you're going to do is you're going to keep the fleximeter over the intercostal area. Okay, and you're going to focus with the flexor or flexor here in the middle phalanx. Middle phalanx. Okay, you're going to focus with the flexor or flexor in the middle phalanx. Okay, so this is going to be the thing. Okay, always when you percuss, the movement should be from the wrist, not from the elbow joint. Okay, elbow joint. Okay, so always whenever you percuss one, two, three. Okay, three times over each area. Okay, and percussion is both felt and here. Okay, and always percuss the identical areas and always keep the same position of your ear, hand, and your wrist when you do percussion. Okay, இதெல்லாம் ரொம்ப ரொம்ப இம்பார்ட்டன்டான பாயிண்ட்ஸ். ஓகே, ஸோ கம்பேர் போத் த சைட்ஸ். Always you have a fleximeter and a flexor. Okay, fleximeter and a flexor. Okay, flexor எப்பவுமே dominant hand யூஸ் பண்றது தான் better. Okay, and every time you percuss 2 to 3 times over each area. Okay, it can be both heard and felt. Okay, heard and felt. These are few important things you have to be very careful whenever you do percussion. Okay, percussion. Then during percussion, okay, you have two kinds of percussion. Okay, that is direct percussion and indirect percussion. ஓகே, டைரக்ட் பர்கஷன்னா என்ன பண்ண போறீங்கன்னா, நீங்க வந்து பேஷண்ட்டை உட்கார வச்சுட்டு லைட்டா இங்க இருக்கிற ஸ்கின்னை வந்து யூஆர் கோயிங் டு ஸ்ட்ரெச் த ஸ்கின். ஓகே, ஸ்ட்ரெச் த ஸ்கின் and directly you're going to percuss over the clavicle. Okay, here the fleximeter is going to be the clavicle. Okay, so this is called as direct percussion. Okay, and indirect percussion is going to be all the other areas percussion. Okay, indirect percussion will be all other areas percussion. Okay, so what are the areas of percussion? Okay, areas of percussion. Whenever you are going to percuss, okay, you are going to percuss over the clavicle. Okay, first is clavicle. First is clavicle. Second, okay, it is going to be supraclavicular region. Okay, clavicle, supraclavicular region, and the supraclavicular region is called as chronic isthmus. Chronic isthmus. Okay, what is this chronic isthmus? Okay, what is this chronic isthmus? Okay, it is a band of resonance of 5 to 7 centimeter in the supraclavicular region. Okay, it is bounded medially by scalenus muscle, laterally by acromion, anteriorly by clavicle, anteriorly clavicle, and posteriorly by trapezius. Okay, so it is a scat. Okay, or a scat. Okay, scalenus, clavicle, acromion, trapezius in this direction. Okay, in this direction. Okay, so in this direction. Okay, so whenever you're going to percuss, the percussion is done by standing behind the patient. Okay, and the resonance in this area is going to be assessed. Okay, whenever there is a hyper resonance in this area, it indicates usually emphysema. Emphysema. Okay, whenever it is decreased, it indicates apical tuberculosis or apical fibrosis. Apical fibrosis. Fibrosis. Okay, so this is very, very important. Okay, so this is going to be a band of resonance of 5 to 7 centimeter. Okay, 5 to 7 centimeter. Very, very important thing is chronic isthmus. Okay, chronic isthmus, and you should never, ever forget to tell this chronic isthmus in exam. Okay, so this is going to be very, very important. Okay, very, very important. Okay, so this is very, very important. Okay, next is uh, next is uh, next part is going to be infraclavicular area. Okay, infraclavicular area. Okay, infraclavicular area. Third one is infraclavicular area. Fourth one is memory area. So as I told you, there is going to be memory area, and many books don't give infra-memory area. Okay, many books don't give infra-memory area. So memory area is usually from second to sixth intercostal spaces. Okay, so this is should be compared to the left side, but left side cannot be compared because of the cardiac dullness. Okay, that you should be able to tell in the exam. Okay, then coming to the axilla. Axilla, okay, you have to go from fourth to seventh intercostal space. Fourth to seventh intercostal space. Then sixth is posterior area, okay, where you are going to spurcus. This is the scapula. This is going to be the scapula. Okay, so now you are going to focus over the suprascapular area. Suprascapular area. Next is interscapular area. Then below infrascapular area. Okay, so these are few areas of auscultation which is very, very important. Okay, very, very important. Okay, very, very important for your exam. Okay, so these are few important things which are emphasized in the exam. Okay, examiner wants to know this. Okay, the examiner wants to know this. Coming to the rules of percussion, which we have already discussed. What is the interpretation of the percussion? Okay, what is the interpretation of the percussion? Okay, now whenever you normally percuss, it is going to be resonant, normal. Okay, normal. Okay, and it is going to be tympanic. Whenever you're percussing over hollow viscous. Okay, so this is going to be a tympanic note whenever you're going to percuss over the drop space. Drop spaceல percuss பண்ணும்போது அங்க வந்து stomach இருக்கும், which I will discuss later. Okay, அங்க வந்து you will get a tympanic tone. Okay, then next is subtympanic. Okay, subtympanic is going to be boxy quality. Like you go to your pathology lab or microbiology lab. Okay, there will be a lot of microscope boxes. Okay, when you percuss over the microscope boxes, okay, you will get one boxy quality. Okay, that kind of sound is called as scoia'c resonance. Okay, so the scoia'c resonance usually seen above the level of pleural effusion. Above the level of pleural effusion. Above the level of pleural effusion. Okay, then after that you're going to have hyperresonant. Hyper. Okay, hyperresonant usually seen in pneumothorax. Pneumothorax. Okay, so this is going to be your percussion note. Okay, followed by you can have impaired note. Impaired means, okay, it is going to be something which is going to be fibrosed or collapsed. Okay, you can tell fibrosis, that is more than enough. Okay, or a cavity surrounded by fibrosis. Cavity surrounded by fibrosis. Okay, then you go to dull note. Dull note. Whenever you have a dull note, okay, remember it is going to be what we can put CC, tells CC. Okay, so it is going to be consolidation where you are going to get a dull note, collapse you are going to get a dull note. Okay, then you can have a very dull, which is going to be stony dull. Stony dull. Okay, stony dull in pleural effusion. Pleural effusion. So this scale is very important. Okay, this scale is very important, and if you know this scale, then you can answer most of the questions. Okay, so whenever there is a fibrosis, okay, you're going to get an impaired note. Okay, and dull note in consolidation and collapse. Okay, you can also remember CCF. Okay, you can also remember CCF. Okay, CCF. ஆஸ்துமால வந்து you don't get anything specific. Okay, ஆஸ்துமால நீங்க ஸ்பெசிஃபிக்கா இப்படிதான் இருக்குன்னு சொல்ல முடியாது. It is all about the lung tissue. Okay, நம்ம பேசுறது எல்லாமே lung tissue, not about the airway. Okay, இந்த findings எல்லாமே about the lung tissue or the parenchyma tissue and not about your airway. Okay, இது எல்லாத்துலயும் நீங்க பாத்தீங்கன்னா lung tissue தான் ஏதோ ஒரு விதத்துல அஃபெக்ட் ஆயிருக்கு. Okay, so this is very important for your exam. Okay, very important for your exam. Definitely இதுல இருந்து question கேட்பாங்க. You should be able to answer this. Okay, so this is very important thing. Okay, then next is crackpot resonance ஒன்று கேட்பாங்க. Okay, example crackpot resonance ஒன்று கேட்பாங்க. Okay, what is this crackpot resonance? Crackpot. Okay, so you take a moist hand, கையில தண்ணி வச்சுட்டு hand எப்படி வச்சுட்டு, ஸோ நீ இப்போ சவுண்ட் வருது இல்லையா, இதுதான் crackpot resonance. ஓகே, இது எப்படின்னா large cavity communicating with the bronchus. Large cavity communicating with bronchus. Then it is going to be crackpot resonance. Okay, crackpot resonance. Coming to the next thing, which is going to be a very important thing, which is going to be tidal percussion. If we are going to see, we will see this in the liver also, but here also I'm going to tell you tidal percussion. Okay, what is this tidal percussion? So this is the sternum of the patient. This is the clavicle. This is the angle of Lewis. Okay, and this angle of Lewis corresponds to second intercostal space. So what you're going to do is you're going to start your percussion from the second intercostal space and you go towards the fifth intercostal space. In fifth intercostal space, you get a dullness. Okay, dullness. Now you tell the patient to inspire. And what happens? This dullness will become resonant. ஏன் இந்த மாதிரி நடக்குது? இங்க ஒரு டல்னஸ் இருக்கு. ஏன் டல்னஸ் இருக்கு? இந்த இடத்துல லிவர் இருக்கு. இங்க லிவர் இருக்கனால இப்போ இன்ஸ்பயர் பண்ணும்போது என்ன ஆகும்? இந்த லிவர் வந்து டவுன் ஆகுறதுனால இந்த இடத்துல வந்து யூ கெட் காலம் ஆஃப் ஏர் பிகாஸ் லங் வந்து எக்ஸ்பேண்ட் ஆகுறதுனால. இப்போ இங்க இடத்துல வந்து உங்களுக்கு யூ கெட் ரெசனன்ட் நோட். ஓகே, திஸ் இஸ் நார்மல். இன்ஸ்டெட் யூ கெட் ஃபோர்த் இன்டர்காஸ்டல் ஸ்பேஸ்ல யூ கெட் டல்னஸ். அப்படின்னா இந்த இடத்துல ஏற்கனவே ஏதோ ஒரு fluid இருக்கு, அதனாலதான் you get a dullness. Okay, and this indicates that patient is having pleural effusion. Okay, fourth intercostal spaceல resonance இருக்கு, fifth intercostal spaceல resonance இருக்கு, further sixth intercostal spaceலயும் resonance இருக்கு. அப்படின்னா உங்க லங் வந்து பெருசா எக்ஸ்பேண்ட் ஆயிருக்கு, அங்க ஏர் இருக்கு. Okay, so whenever it is going to be pneumothorax, okay, whenever it is going to be your emphysema, in all these conditions you will get resonance even little down. Okay, even little down. This is called as a tidal percussion. Okay, tidal percussion. Okay, so that is also very important. Okay, very important. Okay, so இதெல்லாம் வந்து ரொம்ப இம்பார்ட்டன்டான விஷயம். Okay, very very important ஆன விஷயம். Okay, so the liver dullness usually gets at the fifth intercostal space, but if it is not so, then it indicates that there is some kind of pathology. Okay, some kind of pathology. Okay, so hope you understood this concept. Okay, so இது வந்து ரொம்ப ரொம்ப இம்பார்ட்டண்டா எக்ஸாம்ல கேட்கக்கூடிய விஷயம். அதனால வந்து நீங்க வந்து இது வந்து ஆன்சர் பண்றதுக்கு தயாரா இருக்கணும். Okay, so these are few things which are I feel very very important for your exam. Okay, so with this we are finishing the tidal percussion. Okay, tidal percussion. Okay, any doubt here you can let me know, but these are very very important things for your exam. Okay, very very important thing. Okay, next வந்து tidal percussion முடிஞ்சு. Tidal percussion முடிஞ்ச பிறகு அடுத்து என்ன பண்ண போறோம்? அடுத்தது நம்ம போறது வந்து drop space. Okay, drop space. What is this drop space? Okay, drop space. So this drop space in the sixth intercostal space at the costochondral junction, you are going to mark one point. Okay, then ninth intercostal space. Okay, ninth intercostal space along the mid axillary line. Okay, along the mid axillary line, you are going to draw another point. Okay, then lower border of the ribs. Okay, that is lower costal margin ஒரு லைன். இந்த எல்லா லைனையும் நீங்க சேர்க்கிறீங்க. சேர்த்தீங்கன்னா you get one area like this. Okay, this area is usually tympanic. Tympanicனா என்ன மீன் பண்றாங்க அவங்க? Tympanicனா they mean there is a hollow viscous below, and this hollow viscous is stomach. Okay, whenever this hollow viscous is obliterated or covered by some solid tissue, there is going to be obliteration of the drop space. So where your drop space will get obliterated. Okay, whenever there is a left pleural effusion, left lobe of liver, okay, or a growth in the fundus, or your spleen is getting expanded. Okay, when your spleen is getting expanded, in all these conditions there is going to be obliteration of the drop space. Okay, obliteration of the drop space. This is very very important. Okay, so these are few important things. Okay, very very important things for your exam. Okay, for your exam. So you remember these 4 points in drop space, which is going to be sixth, ninth, and lower costal margin. Okay, along the sternal border, along the mid axillary line. Okay, so this is called as drop space dullness. Okay, then next important thing is, okay, next important thing is shifting dullness. Okay, shifting dullness. Shifting dullness is similar to what you do in abdomen. Okay, so what you're going to do is you are going to percuss along the left costal margin. Okay, whenever the patient, you are going to percuss along the left costal margin. Okay, what is going to happen? The patient is going to have, like for example, the patient is like this. Okay, so now what happens? There is going to be air and water. Okay, air and water, which is going to be seen in hydro pneumothorax. Okay, so here the patient is in lateral posture. Whenever the patient is in lateral posture, what is going to happen? Whenever you percuss, what happens? Water goes down and air floats up. So you are going to get areas of hyperresonant dullness. Okay, now you tell the patient to sit. Sit means what is going to happen? The air is going to move down like this way, and water is there in the bottom and air is in the top. Now here you get hyperresonant, here you get dullness. So you're getting a shift of the dullness. Okay, this is going to be called a shifting dullness. Okay, and it is usually seen in patients with hydropneumothorax, and few books says that it is also seen in conditions like pleural effusion also. Okay, and that is pleural effusion வந்து நீங்க பெருசா கன்சிடர் பண்ண வேணாம். நீங்க சொல்ல வேண்டியது எக்ஸாம்ல வந்து ஹைட்ரோனிமோதோராக்ஸ் தான் நீங்க எக்ஸாம்ல சொல்ற மாதிரி இருக்கும். ஹைட்ரோனிமோதோராக்ஸ் தான் எக்ஸாம்ல சொல்ற மாதிரி இருக்கும். Okay, so this is very very important thing. Okay, very very important thing. Then S-shaped curve of Ellis. Okay, so whenever you percuss, okay, whenever you percuss along the posterior side, axillary side, and anterior side. Okay, இங்க percuss பண்ணும்போது இங்க ஒரு band of dullness இருக்கு. இந்த dullness எப்படி இருக்கும்னா இந்த S மாதிரி இருக்கும். S மாதிரி இருக்கும். இந்த band of dullness எப்படி இருக்கும்? இந்த S மாதிரி இருக்கும். இந்த S is called as Ellis shape of L is S-shaped curve. Okay, L is S-shaped curve. Okay, இதுதான் வந்து L is S-shaped curve. You can see the L is S-shaped curve இந்த மாதிரி இருக்கும். So இந்த ஏரியால பாத்தீங்கன்னா you get a resonant note. இந்த ஏரியால you get dull note. Dull note. Okay, so this is going to be your S-shaped curve of Ellis or Ellis S-shaped curve. Okay, so this is going to be your important things about your um, percussion. Okay, percussion examக்கு ரொம்ப ரொம்ப important. பர்கஷன் தெரியாம எக்ஸாமுக்கு போகவே கூடாது. ஓகே, போகவே கூடாது. நெக்ஸ்ட் we are coming to auscultation. ஓகே, auscultation. ஓகே, auscultation பண்ணும்போது when you are examining the patient, always do in sitting posture. Okay, try to do in sitting posture. Okay, so front side எப்பவுமே sitting posture இருக்கணும். பேக் பண்ணும்போது you can tell the patient to lean little forward. Okay, lean little forward. Okay, so whenever you percuss, okay, you did in different maneuvers and all. Okay, but ஆனா auscultation வரும்போது patient வந்து ஒன்னு ஃப்ரண்ட்ல இருக்கும்போது அப்படியே auscultate பண்ணணும். பேக் சைடு போகும்போது patient has to lean forward. Okay, whenever you palpate, compare on both the sides. Okay, compare on both the sides. Okay, that is very important. Okay, very important. Okay, now next is auscultation. Okay, auscultation, you how you're going to do. Okay, how you're going to do, you try to always in chest. Okay, நீங்க என்ன பண்ண போறீங்க, மிட் ஆக்சிலரி லைனுக்கு இந்த பக்கம் ஆஸ்குலேட் பண்ணலாம், இந்த பக்கம் ஆஸ்குலேட் பண்ணலாம். ஓகே, அதே மாதிரி ரெண்டு சைடும் கம்பேர் பண்ணலாம். ஓகே, so whenever you auscultate, okay, the air is going to enter into the trachea. Okay, trachea என்ன ஆகுது, air enter ஆகுது. ஓகே, enter ஆன பிறகு நேரா bronchioles போகுது. அப்ப அங்க ஒரு பாஸ் கிடைக்கும், திருப்பி ஏர் திரும்ப வரும், அப்ப இந்த மாதிரி ஒரு வேவ் கிடைக்கும். ஓகே, so the tracheal breath sound is going to be harsh in quality. Okay, harsh in quality, and it is going to get a curve like this. Okay, curve like this. This is seen in trachea. Whereas whenever you come to bronchus, okay, இங்க வந்து ஏர் கிட்ட வரும்போது இப்படி இருக்கும், ஏர் கிட்ட வரும்போது இப்படி இருக்கும். ஓகே, அந்த மாதிரி ஒரு குவாலிட்டி. ஸோ இது கூட தெரிய தேவையில்லை, ஏர் வரும்போது இந்த இடத்துல ஒரு பாஸ் வரும். ஓகே, பாஸ் வரும். அடுத்தது வெசிகுலர் பிரெத் சவுண்ட். ஓகே, whenever you cross the mid axillary line, okay, mid axillary line, what is going to happen is you're going to have smaller airways. So whenever the air reaches a smaller airways, the air is going to get dissipated. Okay, air is going to get dissipated. When air is going to get dissipated, okay, dissipated, what is going to happen is the sound, okay, will show a relative highness. Okay, relative highness. Okay, which depends upon the number of vibrations. Okay, vibrations of the tissue, and it is going to be a high pitched sound. Okay, high pitched sound, which is going to be called as vesicular breath sound. Okay, vesicular breath sound. Since the air is coming here, okay, since the air is coming to the smaller airways and then it returns back. Okay, there is no pause here. Okay, so there is no pause here, and this is the inspiratory limb which is longer, and this is the expiratory limb which is shorter. Okay, expiratory limb which is shorter. Okay, so this is very important. Okay, very important. Okay, so this is going to be showing a relative highness. Okay, even though the sounds are not of a special quality, அதாவது ஒழுங்கா வந்து டிஸ்ட்ரிக்டா கேட்கலனாலும் அந்த சவுண்ட் வந்து ஒரு மாதிரி high pitched இருக்க சான்ஸ் இருக்கு, and this high pitched sound is going to be the normal vesicular breath sound. Okay, normal vesicular breath sound. Okay, so whenever the air is in the smaller airways, okay, these smaller airways have a sound frequency of around 200 to 400 hertz. Okay, smaller airways there. அதே larger airways பார்த்தீங்கன்னா it is goes up to 2000 hertz. ஓகே, 2000 ஹெர்ட்ஸ் வரைக்கும் போகும். ஓகே, அது கேட்கறதுக்கு சான்ஸ் இருக்கு, ஆனா வந்து கேட்டா சொல்லுங்க. ஓகே, ஏன்னா ஸ்மாலர் ஏர்வேஸ்க்கு வரும்போது the sound gets dampened. ஓகே, the sound gets dampened, அதனால அங்க frequency கம்மி ஆயிடும். ஓகே, frequency கம்மி ஆயிடும். So whenever they have vesicular breath sound, it is going to be a higher pitch sound. ஓகே, higher pitch sound. அது மட்டும் ஞாபகம் வச்சுக்கோங்க. ஓகே, ஞாபகம் வச்சுக்கோங்க. வெரி இம்பார்ட்டன்ட். ஓகே, வெரி இம்பார்ட்டன்ட் திங். ஓகே, ஸோ இது வந்து எக்ஸாம்ல வந்து நிச்சயமா கேட்கக்கூடிய ஒரு விஷயம். Okay, very important thing to be asked. Okay, and the next thing which is asked in exam is what is the pitch meaning? Okay, pitch na என்னன்னு கேட்பாங்க. Okay, so whenever you have pitch, okay, so pitchங்கிறது வந்து the intensity of the sounds. Okay, intensity of the sounds. Okay, so இந்த intensity வந்து அதிகமா இருந்துச்சுன்னா it is high pitch. When the intensity is low, it is called as low pitch. Okay, so pitch is the relative highness or lowness of tone as perceived by the ear. உங்க காதுல கேட்கக்கூடிய அந்த relative highness or lowness of the tone is called as pitch. Okay, pitch. அதனால எந்த ஒரு சவுண்ட் நீங்க கேட்டாலும் pitch வச்சுதான் நீங்க சொல்லணும். ஓகே, pitch வச்சுதான் சொல்லணும். ஓகே, சோ சில டைம் கேட்டிருப்பீங்க நிறைய பேர் ஹை பிட்ச்ல பேசுறா. ஹை பிட்ச்னா the டோனோட intensity and loudness. Okay, that is called as high pitch. Low pitch na again it is going to be the lowness of the sound. Okay, lowness of the sound. Okay, so whenever you have pitch, they are going to ask you about the pitch and its strength. Okay, pitch or strength கேட்க போறாங்க. Okay, so இது வந்து very important thing for your exam. Okay, whenever you auscultate, okay, whenever you auscultate, you are going to get auscultation over anterior surface. Okay, that is clavicular memory area. Okay, அப்புறம் axillary area, அதுக்கப்புறமேட்டா interscapular area, infrascapular area. இது ஏற்கனவே நம்ம பார்த்துட்டோம். இந்த ஏரியாஸ்ல நம்ம auscultate பண்ண போறோம். Okay, then now you come down a little lower. Okay, so now what you're going to do is you're going to get added sounds. Okay, added sounds. When you will get added sounds, whenever there is some pathology in the lung, you are going to get added sounds. Okay, so what are the pathologies you can get added sounds? Imagine there is a consolidation here. Okay, consolidation here. What happens? This is a chest wall. உங்களோட stethoscope வந்து இங்க இருக்கு. ஸ்டெத்தஸ்கோப் இங்க இருக்கு. ஓகே, இந்த மாதிரி ஸ்டெத்தஸ்கோப்பை நீங்க இங்க வைக்கும் போது ஓகே என்ன ஆகுது, பேஷண்ட்டுக்கு வந்து இந்த சவுண்டு இந்த இடத்துக்கு ரீச் பண்ண முடியல, இந்த இடத்துக்கு ப்ராப்பரா ரீச் பண்ண முடியல, அதே இந்த இடத்துல ரீச் பண்ண முடியுது. ஓகே, ஸோ ஸ்டெத்தஸ்கோப் இங்க வைக்கும் போது இந்த டிசிபேஷன் வந்து கம்மியாயிடும். whenever the dissipation கம்மி ஆச்சுன்னா, ஓகே, டிசிபேஷன் கம்மி ஆச்சுன்னா என்ன ஆகும், you are going to get a sound, okay, which is of different quality like your bronchus, and this is called as bronchial breath sound. Okay, bronchial breath sound. bronchial breath sound வந்து நீங்க டிவைட் பண்ணலாம். tubular breath sound டிவைட் பண்ணலாம், amphoric breath sound இது பண்ணலாம், cavernous பண்ணலாம். Okay, first tubular breath sound, the most important thing is it is going to be having a high pitched sound. Okay, it's a high pitched sound, very important. Okay, example ரொம்ப important ஆன விஷயம் high pitched sound. High pitch na the intensity remains unchanged. Okay, intensity remains unchanged. Okay, எப்படி வந்து நீங்க வந்து அந்த சவுண்ட், ஃபார் எக்ஸாம்பிள் பேஷண்ட் வந்து 1 சொல்றீங்களோ அந்த ஒன்னோட சவுண்ட், அந்த லவுட்னஸ் இஸ் ஹியர்ட் unchanged. Okay, that is going to be called as tubular breath sound, and it is seen in pleural effusion. Okay, pleural effusion அதுவும் பார்த்தீங்கன்னா above the level of pleural effusion, above the level of pleural effusion. Okay, then next is consolidation. Very important thing. Okay, very important thing. Then massive pericardial effusion. Okay, massive pericardial effusion, and there will be some kind of mediastinal shift, and this is called as Ewart sign. Ewart sign. But ஆனா எக்ஸாம்ல ரொம்ப முக்கியமான விஷயம் consolidation. Okay, next is amphoric breath sounds. Okay, amphoric breath sounds. Amphoric breath sound is a low pitch sound. Okay, low pitch sound. Okay, low pitch sound. அதுல வந்து அங்கங்க high pitched overtones கிடைக்கும். அதாவது நடுவுல ஒரு சவுண்ட் இருக்கும். Okay, that is called high pitched overtones. அது எப்படி இருக்குன்னு சொல்றேன். ஒரு low pitch sound இருக்கும், பக்கத்திலே ஒரு high pitched overtones இருக்கும். இந்த ரெண்டு சவுண்டும் சேர்ந்து ஒன்னா ப்ரொடியூஸ் ஆகும்போது அது ஒரு மெட்டாலிக் குவாலிட்டியில இருக்கும். ஓகே, மெட்டாலிக் குவாலிட்டியில இருக்கும். ஸோ இந்த மெட்டாலிக் குவாலிட்டி வேணும்னா நம்ம எங்க பார்க்கலாம்னா, இப்போ வந்து நீங்க வந்து ஒரு ரோபோவை பேச சொல்றீங்க. ஓகே, ரோபோவை பேச சொல்றீங்க. இந்த ரோபோ பேசும்போது ஒரு டோன் இருக்கு இல்லையா, அந்த டோன் தான் amphoric breath sound. Okay, amphoric breath sound. Okay, amphoric breath sound. So amphoric breath sound வந்து ஒரு metallic quality sound இருக்கும். Okay, ஒரு metallic quality sound இருக்கும். Where there is going to be a low pitch sound with a high pitched overtones. Okay, high pitched overtones. Okay, very very important for your exam. Okay, very very important for your exam. So இதெல்லாம் வந்து நிச்சயமா உங்க எக்ஸாம்ல வந்து கேட்கக்கூடிய விஷயங்கள். இதுல எந்த காரணம் கொண்டும் நீங்க தப்பு பண்ணக்கூடாது. ஓகே, தப்பு பண்ண கூடாது. So this is going to be your amphoric breath sound. Okay, so amphoric breath sound எங்க இருக்கும்னா whenever there is a large cavity communicating with the bronchus. Whenever there is a large cavity communicating with the bronchus, then what you're going to get is you're going to get amphoric breath sounds. Okay, amphoric breath sounds. Okay, very very important. Okay, very very important thing. Okay, so இது வந்து ரொம்ப ரொம்ப இம்பார்ட்டண்டா சொல்ல வேண்டிய விஷயம். Okay, very very important thing. Okay, then amphoric breath sound வந்து நிச்சயமா வந்து என்ன பிச்சுன்னு கேட்பாங்க. ஸோ நீங்க சொல்லணும் low pitched sound with high pitched overtones. Okay, low pitched sound with high pitched overtones. Okay, அதை நீங்க சொல்லாம இருக்க கூடாது. Okay, then the next breath sound. Okay, next breath sound is going to be our cavernous breath sound. Cavernous breath sound, and this cavernous breath sound is also a breath sound which is going to be low pitched breath sound. Okay, low pitched breath sound. அதுக்கப்புறம் அதுல என்ன ஒரு ஸ்பெஷாலிட்டினா அந்த சவுண்ட் வந்து கேவிட்டியில கேட்கும். ஓகே, லைக் கேவ். ஓகே, கேவ். ஸோ இங்க வந்து இட் இஸ் கோயிங் டு பி irregular cavity. இங்க இட் இஸ் கோயிங் டு பி a smooth walled cavity. இதுவும் ஒரு important difference. Okay, it is going to be a smooth walled cavity. Okay, smooth walled cavity. Okay, so this is very very important for your exam. Okay, very very important for your exam. Okay, so இதெல்லாம் வந்து எக்ஸாம்ல கேட்கக்கூடிய ஒரு important thing. நீங்க எக்காரணத்தை கொண்டு இங்கெல்லாம் தப்பே பண்ணக்கூடாது. ஸோ நம்ம மெயின் ஐடியாவே என்னன்னா எது எது வந்து எக்ஸாமினர் ஹைலைட்டிங்கா உங்களை கேட்க சான்ஸ் இருக்கு, அங்க நம்ம தப்பு பண்ணலாமா தப்பு பண்ணக்கூடாதாங்கிறது தான் முக்கியம். ஓகே, ஸோ இங்கெல்லாம் நீங்க தப்பே பண்ண கூடாது. அது ரொம்ப 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 இம்பார்ட்டன்டான ஒரு விஷயமா இருக்கும் உங்க எக்ஸாம்ல. ஓகே, நீங்க தப்பு பண்ணீங்கன்னா then it is going to be like something you are committing a crime in few areas. ஓகே, அதுல ஒன் ஏரியா வந்து your breath sounds. ஓகே, breath soundsல எக்காரணத்தை கொண்டும் don't commit any kind of crime. Okay, don't commit any kind of crime. Okay, so இது வந்து ரொம்ப ரொம்ப இம்பார்ட்டன்டான ஒரு விஷயம். Okay, very very important for your exam. Okay, then what else is important here? Where you will get diminished breath sound. அது வந்து ஒரு கொஸ்டின் கேட்கலாம். Diminished breath soundனா whenever there is a bronchial obstruction, emphysema, pleural effusion, pneumothorax, thick pleura and fibrosis. எங்கெல்லாம் குவாலிட்டியா உங்களோட லங் இல்லையோ, உங்களோட லங்கோட குவாலிட்டி எங்கெல்லாம் போகுதோ, then you are going to get a decrease in breath sound. Okay, so what are the conditions? Whenever you have a bronchial obstruction. Okay, bronchial obstruction, empyema. Okay, empyema, pleural effusion, pneumothorax, thickened pleura and fibrosis. Okay, in all these conditions you are going to get decrease in the breath sound. Okay, decrease in the breath sound. Okay, so almost I have covered everything, I think so, in our thing. Coming to the last adventitious sounds. Okay, last adventitious sounds. These adventitious sounds are sounds which are heard in addition to your breath sounds. Okay, adventitious sounds are sounds which are heard in addition to your breath sounds. Okay, so what are those sounds? Okay, the first important thing is you have to check whether the sound is continuous or discontinuous. Whenever it is continuous, you have to see for the pitch. Okay, whether it is a high pitch sound or a low pitch sound. Okay, whenever it is continuous and high pitch, there is high chances that it is going to be a wheeze. Okay, or whenever it is low pitch, it is called as a rhonchi. Okay, so this can be further classified into monophonic and polyphonic. Okay, monophonic, okay, is seen in obstruction. Or a single obstruction இருந்துச்சுன்னா, then it is going to be monophonic wheezes. Okay, whenever there is a bronchial asthma, okay, multiple airways are obstructed in multiple level. So here you are going to get a polyphonic breath sound. Okay, polyphonic breath sound. It can be also further classified into sibilant, sonorous. Okay, sibilant na small airway obstruction, sonorous na large airway obstruction. Okay, sibilant na small airway, sibilant சின்னதா இருக்கு, small airway obstruction. Sonorous sonorous louder large airway obstruction. Okay, so this is one way of classification. Okay, then other way of classification is Krebs and plural rub, which are going to be discontinuous sound. Okay, discontinuous sounds are going to be okay. Discontinuous sound can be Krebs and plural rub. Okay, Krebs and plural rub. One second, there is something is happening. Okay. So coming to the Krebs, okay, Krebs, okay. So Krebs is a bubbling sound, okay, bubbling sound, which can be a fine crepitation or coarse crepitation, okay. Fine crepitation na smaller airways, coarse crepitation na larger airways or medium-sized airways, or medium-sized airways. Okay, இங்க வந்து you're going to get a crepitation. Okay, so this bubbling sound எப்படின்னா உங்க கையில இருக்க ஒரு ஃபிங்கர்ல வந்து நீங்க ஒரு ஜெல் தடவிடுங்க. ஜெல் தடவிட்டு ஜெல் வந்து மூவ் பண்ணீங்கன்னா ஒரு ஸ்னாப்பிங் சவுண்ட் இருக்கும் இல்லையா? தட் ஸ்னாப்பிங் சவுண்ட் whenever you hear in your lung, it is going to be an example for crepitation. Okay, crepitation. Okay, crepitations எப்படி எப்படிலாம் நம்ம டிவைட் பண்ணலாம். Okay, so fine crepitations, coarse crepitations divide பண்ணலாம். So how you are going to divide? Okay, I will just put a table here. Okay, you can divide the crepitations into two types. First one, the fine crepitation, coarse crepitation. The fine crepitation எங்கன்னா smaller airways. Whenever the pathology is in smaller airways, you get here coarse crepitation in larger airways. Larger airways. Okay, these fine crepitations are usually heard in inspiration. Okay, the coarse crepitations are usually heard in inspiration and expiration. Okay, whenever you cough, okay, whenever you cough, cough does not modify. The crepitation will not change. Okay, whereas it changes in intensity in patients with the coarse crepitations. Okay, so what are the causes of this fine crepitations? Fine crepitations உங்களை கேட்டாங்கனாலே நீங்க எக்ஸாம்ல சொல்ல போற மொத்த விஷயம் என்னன்னா பல்மனரி edema. ஓகே, செகண்ட் வந்து இன்டர்ஸ்டிஷியல் லங் டிசீஸ். இது ரெண்டும் இம்பார்ட்டண்டா சொல்ல போறீங்க. அதுக்கப்புறமேட்டா தேர்ட் வந்து இண்டெக்ஸ் கிரிப்டேஷன்ஸ். இண்டெக்ஸ் கிரிப்ஸ்னா இனிஷியல் ஃபேஸ் ஆஃப் pneumonia. Initial phase of pneumonia. Okay, whereas coarse crepitations. Okay, coarse crepitations. Where you will get coarse crepitations? Coarse crepitations usually you will get whenever the patient is having bronchiectasis. Okay, bronchiectasis. Okay, then redux crepitations. Okay, redux na towards the recovery. Okay, late phase of pneumonia. Late phase of pneumonia, you get redux crepitation. Okay, so these are the very, very important things. Then another difference here is going to be your crepitations, which can be divided into early, middle, and late. Okay, early crepitations. Okay, early crepitations usually whenever you have acute bronchitis or chronic bronchitis. Okay, so acute bronchitis and chronic bronchitis, you get early repetition. Acute and chronic bronchitis. Then coming to middle crepitations. Okay, middle crepitations now usually resolving infections. Okay, and pulmonary edema. Okay, late inspiratory now, then it is going to be pulmonary fibrosis. Pulmonary fibrosis, very, very important. Okay, pulmonary fibrosis. Okay, pulmonary fibrosis. Okay, coming to biphasic crepitation. Okay, it is usually bronchiectasis. Okay, and it is going to be a coarse crepitation. Okay, coarse crepitation is going to be bilateral uh, or biphasic in bronchiectasis. In the table, the very, 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 very important table for your exam. Very, very important table for your exam. Okay, these are few things which are very, very important. Okay, so next is pleural rub. Okay, pleural rub, any pleural inflammation will get pleural rub. Whenever you hold the breath, it disappears. Okay, whenever you hold the breath, it disappears. That's one important point in this pleural rub. Okay, pleural rub, very, very important. Okay, then coming to the last part, which is going to be vocal resonance. Okay, which we have already seen, I think so. In vocal resonance, you are going to see bronchophony, egophony, whispering pectoraloquy. Okay, bronchophony whenever you auscultate the patient, and whenever the patient is going to tell 1 1 1 1 1. Okay, bronchophony is one where there is going to be increase in loudness, increase in clarity. Okay, there is going to be increase in the loudness, increase in the clarity. That is called as bronchophony. Okay, and it is usually seen in consolidation. It is usually seen in consolidation. Okay, next is egophony. Egophony is one where there is amplification of high frequency sounds. Okay, whenever you tell the patient to tell E, it will be heard as A. That is called as egophony. Whenever you tell the patient to tell E, it is going to be heard as A. So this is going to be consolidation. Okay, and this egophony looks like a bleating of a goat. Bleating of a goat. Okay, so when I tell here E, you can hear the sound E. Now I am telling E. It is like ye. So this is called as a bleating of the goat and called egophony. The last one is whispering pectoraloquy. Okay, whispering pectoraloquy is one where the patient is going to whisper the sound. Okay, and you will feel as if the patient is whispering in your uh, ear. Okay, ear. Okay, so that is going to be called as whispering pectoraloquy, as if they are talking in the earpiece. Okay, bronchophony, as if they are going to talk in the diaphragm of the stethoscope. Okay, diaphragm of the stethoscope. Okay, so these are few important things for your exam. Okay, obliterated drop space. Okay, okay. So this is the drop space. Here we have a drop space. Whenever your liver is enlarged, what happens here? You're going to get dullness. Whenever you have pleural effusion, obliteration of the drop space, splenic enlargement, obliteration of the drop space. Okay, these are the important causes. And one more thing is fundal mass stomach. Okay, this is going to be very, very important. COPD breath sound, COPD ல வந்து எதுவும் பெரிய breath சேஞ்சஸ்லாம் கிடையாது. சிஓபிடி நீங்க தனியா ஒரு என்டிட்டியாவே எடுத்துக்க முடியாது. யூ ஷுட் டேக் இட் either as bronchitis or emphysema. Okay. So these are few important things about your lung. Okay. So with this, we are finishing our examination of the lung. Okay. So lung வந்து respiratory system வந்து very important. Okay. Even though it looks small, it is a high scoring area and highly confusing areas are there. So this is very important. Sorry. Okay. So this is very important. Okay. So next is cardiovascular system. Okay, cardiovascular system. Okay, so it's we'll continue or we'll do it tomorrow. Ultimately we'll complete everything, don't worry, but we'll do it now or we'll continue tomorrow. It's up to you people to decide and tell me. So tomorrow. Okay, so tomorrow we will start with the cardiovascular system. You want cardiovascular system or abdomen GA examination? You want cardiovascular system. Okay, tomorrow we'll start with CVS. Okay, so meet you all tomorrow. Okay, we'll do this thing. Sunday we will have 2 hours of class mostly. Okay, I will tell you the time. I will tell you the timings. Okay, but we will have mostly 2 hours of class. Okay, so morning and evening like that we'll have 2 hours of class. Okay, so thank you all. Take care. Bye.